Hey, Mark Testa here with Regenexx founder and chief medical officer, Dr. Chris Centeno. Today we're going to do another round of Ask Me Anything. Now, not ask me, but ask him anything. And I'm going to ask you the first question. What's new in the regenerative medicine world this week? I know it's changing like on a daily basis.
Yeah, first, we're a couple minutes late, so sorry about that. Just some technical stuff to take care of. Second, what's new? Let's see, what did I blog about this week? I blogged about an umbilical cord stem cell company, Livion,
Right,
who was claiming that the recent tests that we commissioned Colorado State University to perform were done with the wrong culture media. And that was kind of interesting. The CSU used fetal bovine serum, which is the standard culture media, so that was all fiction. But it brings up an interesting point, and that is that we see these birth tissue companies, the exosome companies, literally they can come up with stuff that sounds very scientific, but it's actually really not. It takes just a few seconds to create, for the salesperson to create, and it takes hours to rebut if you actually know which end is up. I also blogged on some interesting stuff just in all the different things that you need to do to run an in-house lab. And it's amazing all the different things that are involved that go into the safety of that facility. So as an example, everything from different types of bacterial testing that have to be done in the lab to training of the processors, trying to make sure the processors are actually doing what they're supposed to be doing, testing the sterility of the processing itself. So for instance, to do that, we use processing blanks. So we'll send out a processing blank to a network site. They'll have to process that using sterile technique and then send it back to us or a third party who can test to see if they got any bacterial contamination. So again, just a small fraction of all the things that we do to make sure that the processing is happening as it's supposed to.
So yeah, we're doing a great job with that. What about these bedside things? Is there any potential for contamination just in these one-size-fits-all machines?
Yeah, there's lots. As an example, you can get serum that accumulates in the machine. So you can have bedside machines that have the serum of 30 or 40 different patients caked onto the side. Obviously, those little kits can break. You've got the sterility involved in getting it into the kit and taking it out of the kit. You've got untrained people who are running these machines who all they know is kind of where the kit goes and where the on button is, but if anything else happens, they get into trouble. So yeah, there's quite a bit that can go wrong there as well.
Yeah, so you've got to take a lot of extra precaution. Ed asks, after a hip replacement, he's still having nerve pain, and he's told stem cells can't be used because of the artificial hip. Is this true?
Yeah, Ed, so nerve pain after hip replacement would come in two different varieties. One variety would be that you had some sort of nerve pain that was causing the hip problem, i.e. a bad nerve in your low back, and they replaced the hip, but it wasn't really the hip that was causing the pain. So we see that all the time. The other is that there was some sort of nerve damage in the hip replacement. So an anterior approach, for instance, can damage the femoral nerve, which is the main nerve that goes down the back. The posterior approach can damage the sciatic nerve. I have a patient right now who had sciatic nerve damage as a result of a hip replacement. So what we did is we actually treated the sciatic nerve itself. So I think the information you were given with regard to stem cells can't be done afterwards has to do with the joint itself, but not if there was nerve damage related to the procedure. We treat a lot of patients who have post-surgical nerve damage. In fact, there's a blog on the Regenexx site from about 3 or 4 blogs ago that talks about treating nerve damage.
All right. Yeah, he says he wasn't having nerve pain prior to surgery.
Yeah, so it's probably then post-surgical nerve damage, and there are ways that can be treated. Usually we'll use platelet lysate nerve hydrodissection, so we'll go in, identify where the nerve is injured, and then do a dissection around that area. In fact, I just treated a woman who had butt implants, and one of them got infected, obviously needed to be taken out. That caused damage to the sciatic nerve. She came to me with a dead leg, basically, and we now have her back to doing box squat jumps at 30 inches. So she's done very, very well with that procedure, but that was damage from the surgery.
Wow. So, yeah, Ed, to your point, I guess you got to ask the right person the right question to get the right answer. Randy asks, he's been on a journey trying to deal with his back pain. He has pain with extension. What could that be? Facets?
Yeah, pain with extension can be pain in the facet joints. That's probably the first thing you would think of. So that has to be ruled out. The way to rule that out would be you could just do some facet joint blocks where you place some cartilage-friendly anesthetic, and it's important to realize that most of the anesthetics used in pain management are cartilage toxic. So the most common one used is bupivacaine or Marcaine, and that will kill cartilage cells pretty dead. So you don't want to use that stuff. So you've got to find a pain management provider or a local Regenix provider that does spine that will use ropivacaine. That's the only anesthetic that's really cartilage friendly. And you'd want to numb out those joints and see if your pain goes away. And then there's the other question of how you got there. Why do those joints hurt? Are they damaged? Are they arthritic? Are there other reasons why they're hurting that need to be treated as well?
Stephen asks an interesting question. How do you know what the strength of SCP injections should be, and what happens to cells once they're injected into the ligaments? How many cells stay in the area?
Yeah, so a bunch of good questions there. The first question, how do we know the right dose? Realize that what we do is we concentrate over baseline. So everyone's got a baseline number of platelets. Some people have more platelets, some people have less. As you get older, the amount of growth factors in those platelets goes down. And if we're talking about treating tendons, we've actually published a paper on this showing that for older tendons, you need to go to a higher dose. So our standard dose for the average tendon in, let's say, the average early middle-aged guy would be 7 times above baseline, or 7x SCP. If you're later middle-aged, it's going to be 10x. And if you're older, that might go up to 14 to 20x. And we've seen, based on that tendon paper, that the higher we went in older tendons, the more stimulus of those tendon cells we got. And then as far as the platelets staying where they should, realize when it comes to tendons like that, there's free collagen. So as soon as those platelets hit that free collagen, they start to form a clot. And that's how the platelets stay there. In addition to that, when it comes to ligaments and tendons, things stay put, meaning that it's like injecting into, if you picture thousands and thousands of little ropes, and all those little ropes are lined up. As you might imagine, if we put a bunch of little tiny marbles in all those little ropes, and they were tightly wound together, the marbles would stay where we put them. So that's what tendons are like. They're like thousands and thousands of tiny little ropes that are bundled together.
Lori asks, if there's thyroid disease, do you know why there's an increased risk for frozen shoulder after PRP? Have you heard that?
Yeah, I think what you're talking about there is more, there's an increased risk for patients who have thyroid disease for adhesive capsulitis, which is frozen shoulder. In addition, there's an increased risk for people who have metabolic syndrome. So if you've got high blood pressure, high triglycerides, wonky blood sugar, there's a much higher risk for adhesive capsulitis as well. So really just an increased risk for adhesive capsulitis, which is the medical name for frozen shoulder.
Linda asks, does chelation affect PRP, and if so, how long should you wait before a procedure?
I don't think anyone knows the answer to that one, Linda, whether chelation will affect the quality of the platelets in PRP. We do know that, as an example, that taking nonsteroidal anti-inflammatory drugs is probably not good for PRP. We know from some of our research that we've done with mesenchymal stem cells that patients that have very high cholesterol and triglyceride levels, their platelets tend to be less effective at growing stem cells. So we know things like that, but we really don't know yet whether chelation has any kind of effect.
Interesting. Stephen asked a similar question that he asked about PRP more with bone marrow concentrate. If you aspirate more cells, do you inject more cells?
We do. So for bone marrow concentrate, realize that we have dosing requirements. So for a large joint, based on the dosing study we published, it's 400 million total nucleated cells. So if you come in and want, for instance, both knees and you're older, we're going to have to take the max amount that we can take out safely, and then hopefully we get 800 million or above, 400 per knee. If we get, let's say, 1 billion, we'll treat both knees very easily. If we get 600 million, then we're only going to treat one knee. And realize that we're really the only folks counting cells out there who have any kind of idea, based on what we've published, how many cells are required. So every place else you could go, you'd get what you get. They'd treat both knees, and if it was not enough, they wouldn't know. Here we know.
Interesting. Stacy asks, what supplements can you take to boost collagen and collagen production, and is it helpful?
Boosting collagen production. So that's a harder one to say, meaning we don't really have good data on that stuff. What we have good data on are things like MSM, glucosamine, curcumin for use in knee osteoarthritis. So the mechanism behind those things is supposed to be that they are joint components. So for instance, for chondroitin and glucosamine, we know based on a number of different high-level studies that they work well or as well as nonsteroidal anti-inflammatory drugs in treating knee osteoarthritis. We know that curcumin works as well as Celebrex in treating knee osteoarthritis. As far as trying to boost collagen production, we don't have any of that kind of clinical research that's been published yet on supplements that are out there. So I can't tell you that if you take collagen pills, for instance, that your tendon healing is going to be faster. That's not been published. I can't tell you if you take glucosamine and chondroitin, your rotator cuff healing is going to be faster, because again, it's not been published. You can certainly theorize that if you were to take collagen, which literally is just gelatin, so if you wanted to get the cheapest collagen out there, just go buy some Knox gelatin and flavor it and eat it, or just put it in your drink, because that's collagen. There's also glucosamine and chondroitin in there. So if you want a really cheap way to boost your collagen intake, whether or not it's going to help tendon healing, I don't know. Just go buy some Knox gelatin at the grocery store.
Interesting. Michelle asks, can you have a second stem cell injection in the same joint, and about how long in between would you wait?
Yeah, Michelle, we did that registry study a long time ago, and basically it showed that in patients that got an initial response, from the second procedure they would get a 15 or 20% boost, so absolute percentage improvement boost. So if they got 40%, they'd go to 55 or 60, that kind of thing. And generally, we would wait a good 3 months in a joint before hitting it again. Same thing for a tendon. So 3 months is about a good time frame to look at.
Great. Nancy states that she had a platelet lysate injection about 4 months ago from C1 to 6. Her hands still go numb while sleeping and has some headaches, and is curious about if it's appropriate now for a repeat.
Yeah, so Nancy, so realize that if your hands are going numb, there could be a couple different causes for that, right? One would be that there are nerves in your neck that are getting compressed, which would be that we would inject those lower neck facet joints and get that to overfill into the epidural space around the nerves. So realize that that's one thing that we might focus on there. And if you got good relief or some relief that was temporary, then you might want to repeat that. Then there's, whether or not there's degenerative disease within the neck, in which case we're going to want to go ahead and treat those ligaments to reduce the extra motion, and or it could be thoracic outlet syndrome up here, in which case we might need to inject platelet lysate there as well. So the answer is, if you got some relief, you might want to repeat it, but we might need to dial in the diagnosis a bit more if you didn't get a lot of relief.
These are great questions, and I want to encourage you, if you know somebody that you work with, a loved one, who are looking for solutions around stem cell injections or surgery alternatives, please share this Facebook Live with them so they can learn from an expert. Anne asks, what age do stem cell quality start to decline?
Yeah, and if you are living and kicking and healthy, your stem cells are doing just great, meaning that we did the world's largest study recently. It's just been submitted for publication, so we'll see when it actually gets published, because that can take anywhere from 2 months to 6 months to jump through all those hoops. But we did the world's largest study on age and the number of stem cells in the bone marrow. There was not a relationship. So once we got to 100 patients, prior studies had only done 30 or 40 patients. Once we got to 100 patients who were all adults, there wasn't a relationship between the number of stem cells in the bone marrow and age. Now, if you look at how fast cells grow in culture, there is a relationship. As you get older, you tend to see that slow down, and the slowdown starts to occur kind of in middle age. But again, if we go the other direction and say, if we look at knee osteoarthritis outcomes and bone marrow, do older patients fare more poorly than younger patients? The answer is no. Younger patients don't have any advantage over older patients. So the answer is, your cells are working just fine to do what they need to do for our purposes, unless you're really, really old, so what I would call the infirmed old. There isn't a problem there. So again, there's the active elderly, there's the sort of late middle-aged active person where I am right now. Then I'm going to get to be the active elderly. And then at some point, there's that last few years of being the infirmed elderly. So I would say that these procedures are probably not really going to work well in the infirmed elderly. But the infirmed elderly is really that last couple of years where you can barely do anything.
Yeah, I want to keep active as I age as well, for sure. Let's see here. Sean asks, sounds like he's got multiple levels, T12, L1, L5, S1, and some anomalies at S1 too. 45 years old, has disc bulges, and just is looking for some direction on where to go at this point.
Yeah, I think the biggest thing you need to keep in mind is that for most of the patients we treat who are just like that, platelet-based therapies work really, really well. Meaning that patients come into the office all the time. I want low back stem cells or upper back stem cells. I look at everything that's going on and say, you know what, platelets will work great here. It's half or a third of the price, and it's going to do just fine. So that's the first thing you need to realize. The second thing you need to realize is, with that many disc bulges, it's really a degenerative, sloppy spine that's the problem. So it's when spines get degenerative, they tend to move around too much. So a big part of trying to treat that kind of spine is going to be putting out the little fires in the facet joints around the nerves, but also tightening ligaments down to reduce motion.
That's great. Ivy wants to thank you for your blogs, especially the aging series.
Oh yeah. I had that mask on this last week. I actually scared the heck out of my wife with that mask, and my son, my high school son, I was kind of scratching on his door, and he came to open it. And he told me he almost shot me. He has like a BB gun in there or something in his room. But it was that I got a lot of Halloween stuff going on with that crazy CPAP mask.
Yeah, I thought it was funny when I saw you scared your wife. Let's see, Becky. Well, let me back up one quick one. And a couple around supplements. Can you take supplements with these procedures before a stem cell procedure? And Becky asked particularly about MSM because it's got an anti-inflammatory component around it.
Yeah, so realize the kind of anti-inflammatory that we're concerned about is the cyclooxygenase pathway. So there's lots of different ways inflammation is managed. Two of the big ones are the LOX and the COX pathway. The COX pathway is where all the non-steroidal anti-inflammatory drugs act, and that's what we're concerned about. We're not concerned about fish oil, for instance, that would act on the other pathway. We're not concerned about fish oil that also has what's called resolvins in it, which are a completely different gig. We're not concerned about glucosamine and chondroitin and curcumin that probably act in a completely different way, in some ways directly on some of the inflammatory cytokines. So we're only concerned about those non-steroidal anti-inflammatory drugs that act on that COX pathway.
Becky asks if PRP or the PICL procedure can raise a Chiari by stabilizing its position and strengthening the ligaments.
Yeah, I doubt it's going to raise a Chiari. You have to realize that. So there's a couple different things with Chiari. The first is whether or not the patient's been imaged upright or lying down. So myself and a few other doctors about 10 years ago published a paper on that there are many more Chiaris detected in upright imaging than there are when you're lying face up in a tube for an MRI or a supine MRI. Then you get into the whole other set of issues, which is the idea of instability versus static imaging. So movement-based imaging versus static imaging. The problem with upper cervical instability is that when you're moving around, things are getting damaged. So in this case, when you're moving around, you're getting a stopper effect, if you will, from the brainstem in a Chiari type malformation or the cerebellum. But realize that that's a movement-based concept. So we take these measurements on static MRIs, but it's the movement that's causing the problem. So by getting rid of the movement, we can help the problem. Now the static MRI may or may not change, but it doesn't really make a difference. We're just using a static MRI because that's the most common thing people have, and you can measure that stuff very easily on static MRI. But it's not at all involved in the concept of why people have problems. People don't have problems because they're lying face up in a tube, which is really how we're measuring that. They've got problems when they're up and about and moving, and that's the concept of instability.
That's great. Stacy asks, after a PICL treatment, she's used hydrocodone and acetaminophen. Is that bad, or is there a better option?
Yeah, those are both just fine. Acetaminophen has a slight anti-inflammatory or has slight anti-inflammatory properties, but it's not going to be a problem with what we're talking about here. The biggest issue would be if you had to take corticosteroids for some reason, or non-steroidal anti-inflammatory drugs, less of an issue, but still a problem. But those two medications, not an issue.
Speaking of steroids, if someone had a epidural steroid traditional injection, how long would you want to wait before doing something around that spinal segment with orthobiologics?
Yeah, a good 6 to 12 weeks. It's going to be about 3 months before that stuff fully wears off, because what that stuff does is it's an incredibly potent anti-inflammatory, but it also kills a lot of the local repair cells. And it's toxic, meaning if I were to take a milligram dose of corticosteroid, which is the common dose range that's injected, and drop it into a stem cell culture or a tendon cell culture or a cartilage cell culture, all of those cells would be dead within 24 hours, just to give you a sense of how toxic that stuff is at that dose. Why do we use those doses? Because it's tradition. It's not because of the science. The science would actually tell us that we would want to use nanogram doses, 1,000,000 times less, because that's what the body uses. But regrettably, that stuff doesn't come in nanogram doses. We use it in nanogram doses here because we have it specially compounded by a pharmacy, but you can't buy it from Joe's medical supply in anything but milligram doses, which is 1,000,000 times too much.
That's amazing. Stephen asks, after an upper cervical procedure, what is more important to address, atlas correction or curve correction?
Yeah, so I always tell patients, if you have been working with someone that does atlas orthogonal or NUCA, and that's working for you, meaning that you're getting good relief for a short-term period of time, a couple days, a week or two, you should continue doing that work, because we'll see patients like that who will increase the amount of time they're holding that adjustment. It'll go from 3 days to 2 weeks to 4 weeks to 6 weeks to 12 weeks, etc. Now, curve restoration is a similar thing, but a little different. There, you're not putting something back into alignment or place. The goal there is to take the weight off of some of those ligaments by getting the normal curve back. And if you, like everyone else, looks at your phone all day, your curve in your neck goes away. So curve restoration puts that back to take the weight off of the upper cervical spine. So literally, and it's probably, regrettably, two different types of chiropractors that do that. You've got upper cervical focused chiropractors who are very good at that, and then you've got chiropractors that do chiropractic biophysics who are good at curve restoration. So the answer to your question is, if you've got a curve problem, you need to get it addressed. And if you've got an upper cervical chiropractor that can give you relief, you should continue with that. Now, some of our upper cervical instability patients, they don't do well with any type of manipulation, so we tell them not to do that, obviously.
Interesting. Nancy asked, what's the best imaging to diagnose knees with grade 4 OA and meniscus tears, MRI or digital motion x-ray?
Yeah, not a digital motion x-ray. An MRI would be the best thing, because the big question for us there is whether or not we're going to have to treat the bone, and the easiest way to see lesions in the bone and swelling in the bone would be MRI.
All right. Stephen asks, if you re-injure an area after treatment, is it game over, or will extra cells facilitate better healing?
If you re-injure something after treatment,
right?
Yeah, a lot of it would depend on what it got re-injured and how. So as an example, let's say you had some PRP in your shoulder rotator cuff, and it did great for a couple years, and you did something stupid. This weekend, actually, I was trying to yank on this giant rubber band thing I was using in our gym, and I probably tweaked my right shoulder. I'm giving it some time to heal. I'll give it a week or so to heal. If it heals, then I will not get it treated. If it doesn't heal, then probably next Monday I'll be getting some repeat PRP injections in the rotator cuff up here. Why did it do that? Because I was incredibly stupid. This was the world's biggest rubber band, and I was trying to put it onto a certain piece of machinery. My son, who's 19, couldn't do it. And of course, I jumped in to see if I could do it. And I did it, but I paid for it.
I call that old man strength.
Yes, that's old man, poor decision making.
Ed's had his knee scoped twice in the last 15 years. HA, Hyalgin, is no longer helping. His doctor's telling him the only thing left is a knee replacement. What are your thoughts on that, and what else can be done to help?
Yeah, that's our sweet spot. Or that reminds me of that scene from from Star Wars where Ian McEwan says, Sith Lords are my speciality. So long story short is that's really our sweet spot or our speciality. That's where we focus, meaning our average patient with knee osteoarthritis has usually had 1 or 2 knee surgeries. They've been told they need a knee replacement, but they basically are told, hey, come back when you just can't stand it because you're pretty young right now. Great time for a knee replacement is generally in your late 60s to early 70s. That's the perfect time. You're 54, so come back in 10 years. And that's our average patient we treat with stem cells in the knee. What can we do there? About 70% of the time, we can get those patients to have between 2 and 7 years of relief. They'll generally need to come back. Our goal is to get them to that point of either they're at that right age for knee replacement and they get that done, or we just keep milking them along as the technology improves.
Yeah, that's great. We see this all the time in the education center where almost every patient has been told they're bone on bone.
Yeah, so yes, bone on. So when it comes to knees, there isn't a relationship between bone on bone osteoarthritis and outcome, meaning that the folks that have more cartilage don't do any better than the folks that have less cartilage, and vice versa. Now hips are different. If you're bone on bone hip with large bone cysts and change in shape of the femoral head, a same-day stem cell procedure isn't going to help you much. I don't care what kind of cells you put in there, it's not going to help very much.
All right. Let's see. That's about it for questions coming in. Anything else? Ask him anything. All right. All right. Any final words of wisdom this week?
Yeah, again, I think, as I've said before, this stuff done correctly is very, very different than what it is we're seeing being done out there. Like all medical procedures, there's vast differences in what people can do and their areas of expertise. So just be careful. It's the hardest thing to explain to a patient is the difference between a good, competent stem cell provider who understands what's going on, what needs to be treated, how to treat it, keep the patient safe, etc., and 95% of what's happening out there, which is just a crazy free-for-all. So just be careful.
2 more quick questions. You good with that?
Yeah.
Okay, good. Gladys asked, she has cranioinstability and EDS. I did a PLM injection in July from CO to C7. Helped for sure, but having more subluxations in the thoracic, ribs, clavicle, shoulder blades, lumbars. Can this be coming from instability? I lost about 58% of my curve, and I notice many times when I do massage in my traps and my upper neck, it cracks a lot. And MRI shows alar and accessory are damaged.
Yeah, so in that situation, a couple things. One is that obviously there's instability in lots of different spots. So in those patients, we'll generally we'll focus that PICL procedure on the alar and accessory ligaments. And in addition to that, treat all of those other areas as well. A lot of patients with instability find that when they get a massage, they might even get worse because they need that muscle tightness and that spasm, if you will, to stabilize things. So when that's taken away, things become more unstable. We treat lots of patients with hypermobility, and we generally treat lots of different areas to try to stabilize those different spots. So in this case, we would probably treat those upper cervical ligaments, but then again, some of those other really bad areas as well.
Okay, last question. Thoughts on a 35-year-old with severe degenerative disc disease in the lumbars and have noticeable changes and most other spinal levels? Not sure what that means, but obviously some other changes maybe in segments above and below.
Yeah, again, I think the biggest thing to understand with that type of degenerative disc disease is that if you've got severe degenerative disc disease where you've got collapse of the vertebrae, the disc space between the vertebrae, you're not going to really, stem cells injected into the disc aren't really going to do anything. You need to stabilize the whole functional spinal segment or functional spinal unit. So that would mean treating the ligaments, the muscles, the facet joints, the irritated nerves. All of that's got to be treated in order to make a patient like that better. And I see patients like that all day, every day, and we get high response rates, about 80%, when we treat the whole functional spinal unit. If we were just to put some stem cells in the disc, it would be 20% or less.
Yeah. Great questions, everyone. Thank you so much. Dr. Centeno, thanks for those great answers. We will be back next Monday. If you know someone who needs to hear this, please share this with them so they can find out some good information and make good decisions.
Okay, thank you very much.